So in the clinic, if a patient walks into the door today who's progressed from frontline, and if you had lurbinectedin available, would you use lurbinectedin over any other agent in the absence of a clinical trial?
I would. As I said, the biggest side effect with topotecan has been myelosuppression and the ability to give it on a scheduled basis. So, or you have to dose reduce in order to decrease the amount of myelosuppression. At least based on what we know with lurbinectedin, I think that has much better toxicity profile, and its myelosuppression seems to be lower than topotecan. So I would definitely use that.
Yeah, I would agree. I think, for these patients who have disease that's not going to be cured, we're looking for the ability to maintain their quality of life, and also, use a number of different tools. So I think this is something that's well tolerated. It has a higher response. It does have a good response rate. I think the interesting question will be for the patients who have platinum resistance versus sensitive disease. I think that the 45% response rate for those patients who had platinum sensitive disease may point to this being an option prior to using platinum again. So I think that's something that remains to be seen, and it certainly depends a little bit about how in my hands this is the patients are doing. We need to get a little more experience with this drug in the clinics.
Yeah, that is a very important point that you bring up about what do you do in platinum sensitive patients. And so far we didn't have any great options, so we used platinum again. Yeah. But now that we have another option which at least appears to be as good, this is definitely something that we could potentially use. Having said that, I think there is still a role for the challenging with platinum. Mm-hmm. We don't have too many great options. So if I have someone who's been 6-7 months since their last dose of platinum and has good performance status, I might tend to challenge them with platinum etoposide again, simply because I know that I can use this drug later on when, as we all know, they will relapse at some point, and the disease-free interval after the second platinum is less than with the first time they get it. So just because with sequencing of drugs, if they have a better performance status, they may be able to tolerate platinum etoposide. Whereas if we give them lurbinectedin first and their performance status worsens when they progress, they may not be able to tolerate platinum etoposide doublet. We'll have to find some other drug at that time. So that is a subtle nuance that I might consider in treating those specific individuals.
Thank you so much. So in the context of immunotherapy and lurbinectedin, again, when this lurbinectedin trial was designed, I don't think so immunotherapy was a standard of care. It was mainly available in clinical trials. So again, going through the clinical study, 8% of the patients had received prior immunotherapy as first line. Again, 2 patients, and second line, 6 patients as a treatment. Again, in a post hoc exploratory analysis of this small group of patients, again, 5, which amounts to 63% of these 8 patients, had durable responses to lurbinectedin, according to investigator assessment. Again, again, immunotherapy and lurbinectedin have different mechanism of action. So it, even when we combine immunotherapy patients who progress from frontline immunotherapy or second line immunotherapy could be still candidates for lurbinectedin. Again, we still wait for further data in this, but again, having another drug in this area is a major boost in the clinic for patients.
Yeah, what you just said makes a lot of sense in the context of what we had discussed earlier about responses to post-immunotherapy chemotherapy. So as Dr. Chang said, her anecdotal response of evidence of great response to topotecan after someone had progressed on checkpoint inhibitor seems to be similar to what we found post hoc in the lurbinectedin study. So there may be some signal there about how previous immunotherapy may prime responses to subsequent cytotoxic chemotherapy. And I think that would be a good topic for further investigation going forward, since there are only a limited number of options for these patients, and we need to be trying to find out creative ways of treating them.
No, perfect. So in summary, I think lurbinectedin appears to be a valuable treatment option in addition to our treatment armamentarium. And the benefit of lurbinectedin compares favorably with that seen historically with topotecan and many of the new agents that have been recently tested in clinical trials in terms of both anti-tumor activity and safety.